Welcome to the Doctors Hospital Distinguished Lecture Series. Every month we invite members of our medical community to speak on topics that matter to you, the Bahamian public. We trust that you will find this information useful. Now sit back, listen, and learn. Isn't your health worth it?
Good evening again, everyone. How are you all tonight? This evening, in fact, rather. Okay, stroke. I'm sure each one of you must know about it. One of your friends, family, someone or the other, a friend, or even in the news day to day, you will hear about it. Stroke. What is stroke? I'm going to be talking about it. A little bit about myself. I am a physical therapist out at Bahamas Medical Center, soon to be Doctors Hospital West. Now, what causes stroke? We're going to be starting with that. A stroke, in our language, what we call it a cerebrovascular accident. In a nutshell, it's a bleed. It's a bleeding into your brain matter in the form of a bleed in the brain matter or the bleed and the blood not reaching the brain matter. So whenever there is a block of flow to the brain, that's when you can get a stroke. What are the symptoms once you get stroke? What should you be looking out for? The person will have difficulty in walking, speaking, and he will have trouble with small day-to-day tasks, like even as small as picking up a fork from the table. How is a stroke manifested? Like I said previously, it is when the blood supply to the part of the brain is affected, stops the blood supply to the brain gets ischemic and it doesn't get enough oxygen for it to survive. The part of the brain dies and you end up with stroke. What are the things you look out for? How will you know that a stroke is impending or you see a stroke is evolving? You look for the patient's face or the person who's by you, his face kind of tilting to the side, drooping. There'll be weakness on one side of the body. There'll be difficulty. You will see the person is not able to speak properly. And that's the time when you start calling emergency. The sooner you call emergency, the better. That's actually your time to call is time to save brain. The sooner the person is able to reach medical care, the more brain can be saved. Now there are 10 signs of stroke, but the common theme in all of them signs is sudden. Not necessarily all of them signs will be there. If some of them signs are there, seek medical attention. One is sudden weakness of the face, arm, or leg, especially on one side of the body. Stroke always happens on one side of the body, be it right side or left side. Number two is a sudden feeling of numbness in the side of the body. It can be again on the face, arm, or leg. Number three, again, a person suddenly has trouble in walking. Again, all of them, like I said, the common theme is sudden. If it is a sudden thing, watch out. A person who experiences sudden vision changes, blurred vision, or trouble with eyesight in one or both the eyes, he might be getting a stroke. A person who experiences a sudden onset of dizziness might be experiencing a stroke. A sudden onset of severe headache that has no known cause, again, sudden, you should look out. A sudden onset of confusion. The person is appearing confused. He is not able to understand or follow your instruction, doesn't know what he is doing. Might be a sign of stroke. A person who exhibits a sudden inability to speak or his speech is slurred. Look out for a stroke. There's difficulty in understanding speech. What he is saying, you're not able to understand what the person is trying to tell you, or he is talking irrationally. Might be a sign of stroke. And a person who is exhibiting sudden loss of balance, he is kind of falling to the side, might be a sign of stroke. So these are all signs of stroke, but again, the common theme is sudden. If any of these happens suddenly, watch out. It's time for you to call emergency or take the person to medical care to rule out that it's not stroke. Again, time saved is brain saved. So the earlier you can reach medical help, the better the chances, the better the outcome. What are the risk factors for stroke? Smoking, alcoholism, not social, but like if you are drinking too much, yes. Obesity, drug abuse, hypertension, diabetes, stress, all these factors contribute or can be leading you to stroke. So cut these things out of your life. Now we have types of stroke. I'm just kind of giving you an outline before I go to the rehab part of it, just for some people who were not here last time, so you all can kind of fall into that part where we get into the rehab part of it. We have types of stroke: ischemic and intracerebral hemorrhage. Ischemic is when the blood supply to the brain tissue is blocked. It can be a thrombus, a clot, which is just forming there, or it can be an embolus, like the clot was somewhere else in the body, but it has traveled all the way to your brain, blocking the blood supply to that part of the brain, causing stroke. Ischemic stroke is about 74% common. Then you have the intracerebral hemorrhage, that's 24%. That is bleeding into the brain. There's a rupture of a blood vessel in the brain itself, bleed into the brain, again lack of blood supply to certain areas of the brain, get stroke. Now as you see the survival rates, that tells you that intracerebral hemorrhage is more dangerous. The survival rate in case of an ischemic stroke in the 30 days, the 30-day survival is 73 to 81%, whereas in case of intracerebral hemorrhage is about 36%. Now we'll be talking about cerebral stroke. In the brain matter, we have different divisions in the brain. So control of the body movements is from cerebrum. So we'll be talking about the cerebral strokes. It is the leading cause of disability worldwide. About 15 million strokes, 5 million out of them die, 5 million permanently disabled. But good thing, the mortality, overall mortality is declining. Long-term survival post-stroke is improving than what it was. So that tells you 1 in 6 people will have a stroke in their lifetime. 1 in 6 people. Now, many a times it is so small or is so short that you wouldn't even know that the person had a stroke. We call it a TIA, a transient ischemic attack. It at the most stays for, if it kind of finishes in 24 hours, we give it TIA. So it was a small stroke, person has moved on. So 1 in 6 will have a stroke in their lifetime. 15 million people experience stroke each year. 6 million of them, 5 to 6 million don't survive. So each second, or in every 6 seconds, someone dies from the stroke worldwide. So 1 minute, we have about 10 people dying of stroke. Again, fourth leading cause of death, 3.65% in adults. When your age is more, like you're past 50 years, you'll have about prevalence of 3.65%. It is the leading cause of long-term disability. Until recently, until 2000s, even in early 2000s, 63% of stroke survivors used to be moderately to severely disabled 3 months after stroke. If you would have checked a person even after 3 months, he has had stroke, they are about 63% disabled. And this is the ratio of men and women. Men always take the lead for everything. So yes, we take care of you all. Now, what are the impairments after the stroke? The stroke has come and gone. What do we see? We get hemiparesis, that's one side of the body is. Paresis is weakness, plegia is completely paralyzed. It can leave you completely paralyzed on one side, or you can have some power left after a stroke, that's paresis. We have emotional lability. All these signs depend on which part of the brain was affected because of the stroke. We have different parts of the brain which serve different functions. So depending on which part of the brain was not getting blood supply or was impaired, you will get these signs. You get Horner's syndrome, vomiting, perceptual defects. Again, like depends. If you are having a stroke on the right side, then you will get a perceptual defect. But if you are having left side stroke, you will get mainly speech defects. But right side stroke, you'll get perceptual defects. You'll get hypertension because of stroke after that, apraxia, headache, confusion, disorientation, memory impairment, aphasia. That's aphasia is inability to speak or difficulty in speaking. That's if you have a left side stroke. Then you can have respiratory problems, decreased cough reflex, swallow reflex, agnosia, incontinence, seizures. Then if we have a focal neurological stroke, the focal signs will be paralysis, sensory loss, language disorder, reflex changes. In case of a TIA, TIA is, like I mentioned earlier, is transient ischemic attack. It lasts from few minutes to 24 hours. After 24 hours, it can stay, but if it resolves within 24 hours, that's your TIA. You get confusion in that, you get vertigo, you get dysarthria, you're not able to speak properly. You get a transient hemiparesis, like you get weakness on one side of the body for a short time. Temporary vision changes, it lasts from a few minutes to 24 hours. So there are cognitive changes, communication changes, motor changes in terms of weakness, sensory changes in terms of having the numbness. Visual, you might have Horner syndrome, which is like drooping of eyelids, or you may have hemianopia. Then there are certain secondary complications post-stroke. It makes you liable, or it makes you vulnerable for recurrent strokes. So you have to watch out for that. DVT, deep vein thrombosis post-stroke. Once you are in bed for a long time, you're susceptible to develop DVT. Pressure sores, again, if you stay in the bed too much after stroke, you will get it if you're not taken care of. Bowel and bladder dysfunction, again, depending on which side of the brain, which part of the brain was affected. Dysphagia is difficulty in eating. Now coming to the topic, the core part that we will be talking about today is rehabilitation. Any of you all have been unlucky enough to go to rehabilitation or know what rehabilitation is? Good. So it comes from a Latin word which means habilitas. It makes to make able. So if there is some disability, rehabilitation will make you able. Or the literal translation is to able again. So the process of helping a person achieve the highest level of function, independence, and quality of life will be rehabilitation. If you go to the literal definition of rehabilitation, it is the active participation, the word active participation of a disabled person and others to reduce the impact of disease and disability on daily life. So if a person is disabled, we need the person's active participation in one way or the other for him to come for rehabilitation. So the recovery after stroke, we are talking about stroke rehabilitation today. So the recovery after stroke is it can be talked about under two heads. One is the neurological recovery and other is the functional recovery. The neurological recovery starts right from spontaneously, like it can be after the blood supply has been restored or once the bleeding to the area has stopped. Then we can start with the spontaneous recovery. And it's usually within the first initial weeks when the penumbral area recovers their function. That's a neurological recovery. Because your weakness and all these are just manifestations of what actually is happening somewhere else. So once that gets resolved, your neurological recovery starts. That's the neurological recovery. But the functional recovery is in everyday function with adaptation and training in presence, absence of natural neurological recovery. This lags neurological recovery by 2 weeks. So once the neurological recovery, so your brain, the blood supply, the blood flow is kind of back to the area. The functional recovery is usually 2 weeks post your neurological recovery. This is where we come in. This is where rehabilitation comes in. We have nothing to do with the neurological recovery because that is with stabilization, medicine, and everything that's been taken care of by the doctors and surgeons if needed. But functional recovery is where the rehab team comes in. So the process of recovery, Majority of the neurological recovery is in the first 3 months. 5% of the patients continue to show recovery for up to 1 year. Return of motor power is not synonymous with recovery of function. So your motor power not necessarily will reach 100% of what it was for you to say that your functional recovery has occurred. Now, when we talk about the neurological recovery, how does it happen? It's resolution of post-stroke edema. After the stroke, there would have been swelling around the brain tissues. Once that swelling kind of resolves, your recovery starts. Reperfusion of ischemic penumbra, the area in your brain which was ischemic, which was not getting oxygen and blood supply, once that area starts perfusing back or the blood starts coming back to that area, that's when your recovery starts. Resorption of local toxins, if there are certain things which have kind of, because of blood, they have not been washed away from the brain matter, once they are resorbed, the recovery starts. Recovery of partially damaged ischemic neurons. Now, neurons are your brain cells. After a stroke, some of them get damaged in the area where the stroke has happened in the brain. So, once they start recovering back, your recovery, neurological recovery starts. The later part of the recovery, there is a neuroplasticity or the ability of the nervous system to modify structural and functional organization. What does that mean? There is collateral sprouting of new synaptic connections. We have neurons or the brain cells, they will be sprouting out branches to make new connections. Say if part of the neuron is dead, the part of the brain cell is dead, it will give some branches. The part which is healthy, it will give some branches out to make new connections so that the connection around the area starts happening. Unmasking of previously latent functional pathways. This is important. Just consider our whole body like electric circuitry, all the nervous system, right from your brain to your toes. Just consider it your electric wiring. In a normal person, we usually use just 15 to 20% of the circuitry that is available. So 80%, at least 80% is untapped. We don't need that or we don't use that. This is what we start using once we lose what we were using. So we start tapping into something which we were not using. So we kind of do something repetitively in rehab. This is again our target area for rehab people to unmask the previously latent functional pathways. Reversibility from diasthesis. This is again the injury is somewhere, the cause is somewhere. Once that cause starts getting better, over a period of time, your functional recovery, the later recovery comes in. Denervation supersensitivity. Again, your nerves which are there, they start firing more than they were firing before. Whatever is left of them, they try to take over or they try to help what is not there now. So if you were giving, there were say 100 nerves were there, each one was giving one, say 50 of them died, 50 are there, they try to start giving two potentials to kind of cover up. Functional recovery is when we see improvement in independence in areas of self-care and mobility, when the person is able to do their activities of daily living, like able to walk, able to do their bed activities, combing, eating, dressing. If he's able to do that, that tells us like the person is improving functionally. It is dependent on the quality and intensity of therapy. Like I mentioned, in the neurological recovery as a therapist, I won't be doing anything, if at all. But functional recovery is where I will be helping as a therapist. I'll be dealing with the functional part of it. It is also dependent on patient's motivation. Besides the quality and intensity of therapy, also on patient's motivation, how motivated the patient is to get better. And it's modifiable by interventions that we do in rehabilitation, what we do to kind of improve that. After a stroke, 10% of the patients have complete spontaneous recovery. They don't need rehab. If you ever get stroke, hope to be in that 10%. 10% do not benefit from rehab due to the severity of the lesion, due to the severity of the blood loss or the area that was kind of affected. So 10% do not get better no matter what. But 80% will benefit from rehabilitation. That's a big number. Now, rehabilitation is a interdisciplinary team. We have a physician, nurse, physiotherapist, occupational therapist, speech therapist, psychologist, social worker, prosthetist and orthotist, and a dietitian. Everyone has to play a part if the rehabilitation is to be complete. Now coming to the early phase, what do we do as a rehabilitation person? What do we do? We have a saying, a physician or a surgeon might put the life back in you, but a rehab person will put you back to life. So medicine may add years to your life, but rehab will add life to your years. So we should start rehab as soon as the stroke is complete and the vitals are stable. Vitals are stable, like in terms of your blood pressure. In the initial stages, it has to be stable before you start, which usually occurs in 48 hours. So as soon as the condition is stable, start with active mobilization, if it is there. If it is not there, then you start with the passive mobilization. The earlier we mobilize or we do our interventions as the rehab team, it reduces the complications that the patient might end up into. It has a strong positive psychological benefit by starting it early. Now, how far can the patient tolerate? Many a times we see the patient is not able or is not complying with us. It can be also because of the stroke severity the person is having. So the compliance, one of the things that we have to look out is for stroke severity, how severe the stroke was, the medical stability, the mental status, and the level of function the person comes in with. In the early mobilization, we just start the person in the bed itself. We call it bed mobilization in our world. We do range of motion exercises. We do positioning of the patient. We keep on changing the position of the patient because the patient is bed bound now, is not able to move one side of the body. So we start coming in. If he is not able to do totally, we start with passively. And as the patient gets better, we start encouraging him to do it actively over time. Range of motion exercises are making sure whatever range the joint, each joint we have to put it through range of motion, hold a full range of motion exercise twice a day at least. That is when the patient is in the hospital. We do in your leg or lower limb, we do up and down, in and out, move your leg in and out, do your ankle, toes. Same thing, we do the upper arm, the whole shoulder, the elbow, the fingers, the wrist, besides the rolling, moving the person in the bed. We have to start. And at that time, also advisable is to try and converse, communicate, or attend the patient to the side of the paralysis. If his paralysis is on the right side, try to arrange it in such a way that the person is facing the majority of the room on the right side. If my right side is paralyzed, this is how I should be positioned in the room, in the bed, so that I am forced to turn and look onto my right side, because many a times they have hemineglect, they even don't know they have right side of the body. So you try to make them respond to the side of the body. Say you want to a phone call, anything, the phone, any kind of interaction should be started on the side of the body that is paralyzed. Now, if you have a stroke on the right side and you kind of keep the person positioned in a way that his left side is facing the majority of the room, it doesn't help the cause. Then we start some specific tasks like sitting up, turning from side to side once the patient is able. If he is not able, we do it passively. We keep doing it passively till the person starts getting some power. And we start the self-care activities where occupational therapists do come in a lot, helping the patient with the self-care activities in terms of feeding, grooming, dressing, start training them as early as we can. Now, late rehabilitation will cause psychological maladjustment, depression, sexual problems, vocational in terms of their job, driving. It will make the person need certain equipments or aids. Spasticity. Spasticity is increased tone in your muscles. That's basically resistance. Then some common things are hemiplegic shoulder pain. The side of the weakness will end up having pain in the right side. It could be basically because of poor handling of the patient or it could be neglect, like you didn't do anything. So the person starts feeling pain on the right side, on the same side as of paralysis, which in turn can cause injury to your musculature, spasticity again, subluxation of the shoulder, and CRPS. Complex regional pain syndrome is wherein the person will start having pain right from the shoulder all the way to his fingertips. And contractures. Contractures is the person, if he is not had any rehab, will get into certain positions, like he is not able to stretch his elbow fully after that, or the hand just stays like that or stays like that, depending on the positioning or the synergy that he presents with. And then there is another central post-stroke pain. This is something which has to be managed medically. What are the criteria for admission to a rehab program? The neurological status has to be stable. There has to be enough neurological deficit for which he needs it. It has to be identified disability affecting for at least two of the following. What is mobility, that the person is not mobile enough, he is not able to take care of himself, he is not able to communicate, he doesn't have bowel and bladder control, he is not able to swallow. Two of these things have to be there for the person to be admitted to a rehab program, and the person should have enough cognition to learn, because this is the active stage now, that the person should be able to understand what is asked of him to perform for him to learn. And he should have enough communicative ability in terms of, it can be in terms of being able to talk or point out using his gestures, and he should be able to tolerate the active program. And from the therapeutic point, I mean from the rehab point, there should be some achievable goals for which the person will be admitted to a rehab program. There are stages after stroke that a person goes through for recovery. We can talk to them in about 6 stages. The 7th stage is when the person is totally fine. First is flaccidity. Flaccidity is right after the stroke, the person is not able to move totally paralyzed. It's flaccid, is stage 1. Stage 2 is that when the synergies are movement patterns, they start coming in. That is because of spasticity. So the spasticity starts setting in. That is stage 2. Every stroke will go through these. Now, each phase will be different in different people. Like how long a person will be in flaccid stage varies from one to another. How long he will be in stage 2 when there will be some spasticity varies. 3rd stage, there will be marked spasticity. The person is really spastic, like there is a lot of muscle tone. 4th is you start out of synergy patterns and less spasticity. 5th is you gain some control of movement. 6th is there is isolated movement possible, and 7 is normal. When we talk about spasticity is, say, a synergy pattern. If I tell you to, can you do this? I'm able to do it just at the wrist. But if he is having a synergy pattern, in doing this, he will end up doing this. This will be a pattern he has. This is a pattern. So that's what it says, like marked spasticity. That's what happens when. Then when you are able to do selective movement, you are able to do only this much, but maybe towards the end you start going like this. You are able to do most of it here, but end you kind of come in with a bit of spasticity. So end is when he is able to do the isolated movement as we ask him to do. We ask him to flex his wrist, he is able to do that without his elbow and shoulder coming in. So these are the stages of spasticity. So flaccid limb, some spasticity with weak flexors and extensor synergies. Some people have the synergy in flexion, some of them have an extension. Like for example, if I tell him to stretch your knee, I want you to stretch your knee. He will stretch his knee, but his hip also will kind of extend. So I'll tell him to, can you do this? Can you do straighten your knee like this? As he does it, he kind of does this. So he is not able to isolate the leg. That is an extensor synergy. This example I gave you was a flexor synergy. Or you tell him to bend your knee. Can you bend your knee like this? He will go like this. These are the synergy patterns. So the voluntary movement, when you tell him to do the voluntary movement, he does it in patterns. You tell him to bend your knee in stage 3, he is not able to do it out of pattern. He will do it with a synergy. You tell him to bend his knee, he will bend hip and his ankle too. There will be some selective, in stage 4, there will be some selective activation of muscles outside of the synergy patterns. Like he is able to do this, to start with he is able to do it, but when he tries to do more, he ends up flexing his knee. 5th is most limb movement independent from limb synergy. Spasticity is further reduced but still present with rapid movements. He is able to do this, but if you tell him to do it fast, he is not able to isolate it with fast movements. 6th will be most limb movement is independent from limb synergy. Spasticity further reduced but still present with rapid movements. And the 7th is near normal coordination with isolated movements. Return to work, it's important determinant of quality of life. When the person, in the later part of the rehab, when the person has kind of achieved certain goals, we start what we call work hardening. We start training him as much near to normal what he was doing before. This is the greatest opportunity to support vocational reintegration in the areas of education and advocacy. Then what do we use? What is our toolbox? Number 1 is conventional methods. Conventional methods is what is used worldwide. Every place, any rehab place, they will use conventional methods. They are strengthening, stretching, positioning. They come under conventional methods. We have CIMT, constraint-induced movement therapy, mental imagery, functional FES, functional electrical stimulation. We have transcranial magnetic stimulation. All these are done at like big centers. They don't happen at every place. Transcranial direct cortical stimulation, virtual rehab, and robotic technology. So in our conventional methods, we attempt to retrain the weak muscles to re-education. We make the person do the same movement what is weak plenty of times in different positions to strengthen that muscle. We stretch out the tight structure so the person doesn't go into what we call contractures, wherein we are not able to extend or flex because the person's muscles have got so short that we are not able to do it. So we prevent that by stretching. Now there are different approaches to the conventional methods. Conventional methods can be Bobath, Brainstorm, PNF. Now they each, like I said, methods are different but the goal is same. When we have initially we have flaccid, like the first stage of stroke is flaccid when the person doesn't have any movement. They differ right from there, all these 3 methods, but all of them are effective if done properly. Bobath suggests that we should let the person kind of, move the way the movement comes in and, go with it. Sorry, it is the RIP, it is the RIP, the Bobath is RIP, the Brainstorm is the one which kind of tells you do what you will. Bobath basically positions, like for example, we use a lot of splints so that the person doesn't go into a synergy. Bobath prevents synergy. The normal thing would have been the flexion synergy to set in, but Bobath, if you follow Bobath's technique, the person doesn't go into a synergy pattern. You use different braces, use different positions, what we call RIPs, reflex inhibition postures, positions, so that the person doesn't go in synergy. And you always only promote a normal pattern. Brainstorm on the other side, which is older than Bobath, was kind of let the movement come in, let the synergy come in, and then we will break down the synergies to gain the normal pattern of movement over time. PNF, again an old technique, but most commonly used is PNF. These are diagonal patterns. These are more, they go with the functional patterns that are present that we need for our day-to-day life activity. Like we do not do something straight. We don't bend our elbow for any activity like this. If we bend our elbow, we go like this. So these are the diagonal patterns with PNF. And with PNF, we use the stronger muscles that are present, or the stronger musculature out of the synergy that is present. We use that to strengthen the weaker ones. There are many components of each of them. I'm not going to go into them. CIMT is constraint induced movement therapy, wherein we constrain one side of the body, the normal side of the body. We just wrap it. We don't let the person use that side of the body. So if I'm hemiplegic on the right side, or if I'm weak on the right side, I will wrap up my left side of the body, so that when I need to do something, I would have automatically done it with the left one because my right isn't working, but I am forced to try and kind of use my right side. That's the constraint induced movement therapy. But it is constrained now, and it is to be constrained 90% of the patient's wake time. So if he's awake for 12 hours a day, we have to keep it constrained. We have to keep it tightened up for about 11 hours. We must have some wrist and finger function if we are trying to use the CIMT. You see in the picture, like his right arm is blocked and he is forced to use the left side to do his activities. Used in many parts of the world, especially in Europe and India. You have a mirror. You put the normal side of the body inside that. There's a box. You put a mirror, or the box has a mirror on the outside of the body. So the normal arm is inside the box. We keep the weak arm on the right, on the outside of the box. So we try to mirror what is happening inside the box, which the person is not able to see. Only he is able to see is the weak arm. So when we are moving this side, we tell him to try to mirror it with the left side. So basically he's just using the same weak side of the arm. Then we have the FES, functional electrical stimulation. The most common remnants post-stroke is the person has a foot drop. Like the person, even everything, now his rehab is complete, but certain things we are not able to help with, which is the remnant of the stroke. That is, the person's foot is not kind of able to flex up or dorsiflex. So these are, FES is used in those cases. Likewise for the wrist. These are the two terminal joints of the body, the foot and the wrist. Many a times that is what the patient is left with. It doesn't get better. So we use this FES. It's used as a neuroprosthesis, functional aid to performing ADL, can aid motor recovery. We have it for the lower arm also. When the person is, it has a sensor actually. So once we are once we have to lift, or say for example we are moving our leg, as soon as we start to move our leg, the sensor picks it up and it automatically fires some electrical impulses, making the foot to come up. So when you walk, it fires your leg to dorsiflex your ankles so that you are clearing your leg and able to walk. Likewise for the wrist also, with the same thing. When as soon as you go up, it will kind of cause the wrist to extend. This helps in more fluid gait, has a gait sensor, miniature control unit, wireless. It helps in increasing the walking speed. Then now onwards, these are things which are done at bigger centers. Transcranial magnetic stimulation. We have the transcranial direct cortical stimulation. And the other thing is the virtual rehab. It has shown to improvement in balance and gait. We have immersive and non-immersive in virtual rehab. Immersive is wherein the person is actually like with those VR, virtual reality. I don't know how many of you all know about those boom boxes. You kind of put them on and the person feels like he is in a VR environment. So that's a total immersive. Versus non-immersive is what he sees on a display unit. He is told to do the same thing, like the Wii games, play with the TV. That's a non-immersive one. The other is EMG biofeedback. EMG biofeedback again is kind of a non-immersive one, wherein the person is in front of the monitor and we have certain cues in terms of audio or video which kind of monitor your responses. It encourages you to do the activity. Then the robotic technology. This helps us wherever it is available. It helps us to do the repetitive movements with less of efforts of human efforts, because rehab needs a lot of movement. It's highly reproducible motor learning experience, relieves the strenuous repetitive effort of the therapist, because if we have to say move your limb through the range 10 times, 20 times, 30 times, or your patient attendant who has to do it once you are home, it will tire you out. But this is very expensive. I don't know where all we can be using this. Now the outcome measures after stroke, what are our chances? It depends on the stroke severity. If you have no stroke, so the brain impact density is hardly anything. So as you kind of go down to severe stroke, your density brain density also increases, the affection. Then you have the upper and lower extremity function, which is the Fugel-Meyer. These are different scales that we use to measure how severe the stroke is. Visual perception, the balance, Berg balance, cognition, MMSE. Then you have ADL's ambulation, FIM score. FIM score is commonly used for the stroke cases and the Barthel index. The FIM score we have up to 7, like 1 is totally dependent and 7 is independent. So if the person is dependent for more than 75% of the effort, we call him a totally dependent. His FIM score is 1. So as the person gets better, the score is 7. Independent, he doesn't need anything. So depending on what score you come in with, what FIM score you come in with for the rehab program, your chances depend on that. If your score is low, if you're totally dependent, your outcome also will not be that great. FIM is functional independence measure. We have 18 items that we kind of categorize and then tell you what your score is. They are self-care, dress, eat, groom, toilet, bathe, sphincter control on bowel and bladder, transfers, locomotion, communication, social cognition. It's scored into 1 to 7 levels ranging from 1 to 7. So approximately 1 in 10 functionally independent at the time of stroke, and nearly 1/2 are independent at 6 months. So 50% of the people who had stroke after rehab will be independent at 6 months. Most improvements in activities of daily living occur during the first 6 months. So your chances of recovery are very high in the first 6 months. But if you are chronic, if you have not kind of gained anything much in your first 6 months, your recovery can still be there, but there's only 5% chances of you to get more improvements after that. It's up to 12 months. Now some people do report having improvements up to 2 years after stroke, but those the evidence doesn't support much of that. Like even after 2 years and more, you feel you are getting improvements. The predictors of functional outcome is how severe your stroke was, your age, your sitting balance at the time, your admission functional independence measure score, and your prognosis. The best neurological recovery is seen in 11 weeks, roughly 3 months for 95% of the patients. Prognosis in patients with mild or moderate stroke is usually excellent, but to those who have severe stroke, they don't have a good outcome. Most ADL recovery on Barthel index is 12.5 weeks with daily physiotherapy and occupational therapy, especially, and speech if they need on a daily basis. But recovery, like I said, some cases they do report even up to 2 years or more. Periodic rehabilitation interventions may be made necessary to maintain function. In case we have seen the recovery, like if you have got the recovery about say 90%, the best recovery has happened in the first 11 weeks, to maintain that, you will need periodic rehabilitation interventions. Now the poor prognosis is if you have severe proximal spasticity, prolonged flaccid period. If we remember from the first one, we talked about the stages the person goes through. If the person stays in stage 1 for a longer period, the prognosis for outcome is not good. Absence of voluntary hand movements at 4 to 6 weeks. So after a stroke, if you see the person doesn't have any movement in his hand after 6 weeks, the prognosis is not good. Onset of movement after 2 to 4 weeks. So if the flaccid part, stage 1 and stage 2, stays for about 2 to 4 weeks, again the outcome is not that good. Full recovery is usually complete within 3 months of onset. The disabilities that you come up with at 6 months post-stroke is unable to walk. 15% of the people at 6 months after stroke are not able to walk. They need assist to transfer, 20% of them. 50% need assist to bathe. 30% need assist to dress. So functional and social outcome, one of the most striking aspects of caring for stroke patients is common observation that their physical performance, functional abilities, quality of life are considerably better after rehabilitation and during long-term care than immediately after the stroke. Predictors, again, they are the type, distribution pattern, and the severity of physical impairment. That is the predictor, how what your outcome is going to be like. then your cognitive, your language, communication and learning ability, the number, types and severity of comorbid medical conditions, like if besides stroke, if he has anything else that is happening, if he is diabetic, if he is hypertensive, if he has heart ailments, if these are comorbid things that he is having, that will also impact. Coping ability and coping style, how much is the patient motivated, how much can he cope with, that also comes into the outcome. Nature and degree of family and other social support that the person has, and the quality of specific rehabilitation training program. All these are the predictors of outcome, what outcome we get. Again, the strongest predictor of discharge is his admission at functional ability, how able he was, what he could do. If he was not able to do anything, so your outcome at the end will not be that great. But if he came in with a film score of 4 or 3, you are looking at a better outcome. The strongest predictors of adverse outcome are coma at onset. At the time of stroke, if he had coma, your outcome is not going to be great. If there is persistent incontinence, if he doesn't have control on his bowel and bladder, if he has poor cognitive function, severe hemiplegia, lack of return of motor function after 1 month, if there was a previous stroke, if there is visuospatial perceptual deficit, unilateral hemineglect, if there is a cardiovascular disease, if the lesion was big, if there is presence of multiple neurological deficits, these are predictors of adverse outcome. So stroke rehab, what are our options here? Doctors Hospital provides you 2 locations. One is, in fact, 3 locations. One is the inpatient rehab. If the patient, when he comes in with, you have the inpatient where once the patient is admitted, they take care of the patients who have stroke. Second is the outpatient rehab, which is on Collins Avenue. The third one is Doctors Hospital Out West, which is still called BMC, but shortly will be named as Doctors Hospital West. And we are on the verge of getting another thing, that is SNF, which is in the works. Skilled nursing facility, that will be soon, Doctors Hospital will be giving that out. At Bahamas Medical Center or Doctors Hospital Out West, we also do have an aquatic program for the senior people, or this is also used for the neurological patients, those who are not having enough muscle power. We treat them in water, which is a heated pool. And there we also have one more program going on, what we call post-rehab. Post-rehab is once you're done with the therapist, but you still need extended care. And financially it is not all the time possible for you to be able to afford a therapist or the rehab. We have the post-rehab care, which is the oversight is by the physiotherapist, but the exercise physiologists do take care of the patients, and they follow the protocol, what the physiotherapist tells them to do, at a much cheaper rate than they would have to if they had to see a physiotherapist for that. So these are the 2 things we are offering at BMC Out West, more than what we already offer at Doctors Hospital Collins Avenue.